With a case like her where she's a really good mover and there's not that many great audits, in
Hmm.
theory, could you just have jumped to where you got in like visit three and visit four, where you started doing a lot more of like different ballistic movements with her and just tried to like introduce some tolerance into that and just be like, let's see how that she responds to that?
You could, but this would be my take. So this last visit, I took it back down because why? She's also in the throes of practice, right? So
Yeah, she's doing
in
a
my
lot.
opinion, I don't want to be like, well, I'm gonna start at the highest level that you fail right away. It's like I wanted to hedge my bets, right? Like, hey, there's lower level stuff that you're not good at. She's not perfect at central stabilizing. Hey, that's kind of paramount to what most of us would agree with from just a rehab standpoint. So I start there for a reason. And I literally told her at the beginning of this last visit, we're going to break you back down, right? So we went back down to the ground, low oblique sits, working back up. And I said, I want to find out where you fail. What was an oblique squat? That's where I left, right? I would have never seen that had I went to ballistic stuff. And then what? You're overlying more compensation on compensation, which is kind of the crux of it. So again, we have this assessment process that relies heavily on functional audits, but we even say in art of assessment, when you've cleared all your functional audits, which maybe is an impossibility, but let's say you've had like a primary, secondary, tertiary, you clear them, you should be moving on to specific movement testing, return to play criteria, or HPL stuff where you're like, oh, I'm working on the next thing, and you're not always going back because otherwise everybody would be done with treatment 3 to 4 visits in,
Mm-hmm.
right? Ideal world, because they're probably going to be out of pain. The pain generators are probably trigger points, lack of range of motion, the things that you're actually working on to get rid of pain. And then you'd be like, oh shit, what am I going to work on? Which I think isn't an uncommon question to ask yourself when you're new in practice because it's hard to have the immediate, like, well, I see this and I know where I'm going to go. And then being able to have that conversation and then also like check those boxes as you go.
Mm-hmm.
Otherwise, I did that early in my career where it's just like, you run into like, oh, you're doing pretty good. Yeah, well, I'll see you in a month. And,
Something happens 3 weeks later, and
yeah. Or,
yeah.
yeah, they never come back and you think they're good. Yeah, something like that. So that's a great question. Um, I would just say, again, especially the early stages of your career, just don't skip steps. Just like, whether that's going through a DNS progression or some rehab progression, there's stuff to work on with her foot, right? On that side, that's needs some help. I could be really picky, and sometimes you could be too picky and be like, oh, I need 20 visits with you. Like nobody's gonna do that. She might, I just don't think that's the best thing for her, especially after
Mm-hmm.
8 months of PT. Last thing I
Yeah.
want that girl to do is spend more time in an office,
Yeah.
right? All right, let's move it into general questions or anything else, but this will go behind the residency wall from this point forward. So any other questions in general or anything?
Yeah, I got one.
Yeah.
So I've heard you talk about this recently. I don't know if it was on a different podcast or whatever, but of the patients you see, if you're going to draw a pie chart, how many of them are affected by some sort of like sensitization or effective mechanism, whatever like classification they have? Um, like a large part of their cases is
Hmm.
that instead of just
Yeah, because
what we're
it's,
taught, essentially. Yeah.
it's every patient. That
Yeah.
process starts immediately, but the large, where that's, I don't know if I should say the focus. And we had a big discussion about this week. Uh, I don't know if I could put a good percentage on it because I'd have to like sit down and look at all my cases. I would say maybe it's split down the middle, right? But it literally is the spectrum, but I think the spectrum is not set for each patient. So what I mean by that, it's a moving target. So if I get somebody like my 70-year-old woman that has legitimate mechanical things, a lot of stuff I could work on, right? Like she doesn't top tier stuff. I don't want to do her case, but we worked on T-spine rotation first with her because she had an asymmetry. She also had some discomfort, but I knew in my mind I'm still going down this kind of protocolish path. But where did I go visit two with her? You'd say more of a chronic pain approach. I didn't touch her second visit. We did rotation drills. We did some T-spine extension drills. We did some overpressure lumbar flexion stuff. And then we went into deadlifts on purpose from a chronic pain. I need to have her. But what did I do the last visit I saw her? Threw some cups on her back, did some flexion, adjusted her T-spine. Like I play that game, and I'm at this point, I tell people what I'm doing. I mean, before sometimes they're like, what the hell are you telling me you're not going to touch me? Like that seems weird. Or, hey, I'm going to do this to your back to make your back feel better because I'm about ready to challenge the snot out of your lumbar spine. So I'm very just like, with what I'm doing. Yeah, I'd say maybe down the middle, maybe 40%. I think also each one of us has like Daniel, I think, has built a practice that is not a lot of those patients because he has a lot of recurrent patients. You might be like, oh, maybe they're all chronic pain, effective. But I don't think as much versus like Sloan, a lot.
Yeah, she more than 40.
Bedside manner, right? Through the roof. People attach themselves to that. And then that's the referral type she gets. So that's a default. Again, it's just a spectrum. So it's hard because like you'll have a pro athlete, huge mechanical issue, but you better treat the psychosocial aspect of that first before you address the mechanical. Because what are you doing? You're making them worse in the long term, even though there could be something massive that you feel like you need to change from a functional standpoint. But if you don't sell it right, and some people are not going to last with you long enough to go through this whole process where you're like, oh, I sold this right. Now I'm changing the mechanics. But if you're creating your Kevin Kelly, 1,000 raving fans, best client ever, approach them in that manner. Don't be like, well, I know that's the best thing for them, but I'm gonna just smash their CT junction for 6 visits because that's what they kind of expect. No, like give them what you think is best for them that aligns with their goals. You're gonna create a great patient for you or not, and then you got to be okay with that at the end of the day. But you're gonna win when you play to what's for them, and you're doing the best for them by that, even though they may think it's not. And that's the probably toughest thing to reconcile practices. Aligning not goals, but aligning wants versus needs. That's really tough, I would say. Probably the toughest thing. Yeah. What else we got? Anything? Cool. If not, we don't have to hang.
Mine was kind of the question you asked in the Facebook group, kind of like what people thought about the residency and all that. I thought of it when we were doing our interview and we are talking about art of the assessment. I thought it'd be cool, like a cool extension off of that, where there's like all these like different parts of art of assessment, and there's all these like different things that you've read or like, okay, you guys should read about this, where you can have it like organized in a way where it's like this one specific thing we're going to focus on, and you can read like X, Y, and Z about it. And then you could even have it at the back end where the case studies kind of focus on that aspect. And then when people come into it, they've had something read that's like related to that. And then it would kind of change the dynamic.
Seth brought that up because Seth, I think I mentioned Seth's helped me a lot with art of assessment. So we're talking about, a big part of it's like the 6 hats, the 6 thinking hats of we were going to just start giving people the book, everybody in the class instead of doing a giveaway. But we might actually, if you attend the class, that book gets mailed to you. You have to read that. And then we have other suggested reading, and we literally going to have like a quiz, kind of like now for the SFMA, you have the pre-work you do before you go to the live class. Because the toughest thing with art of assessment is what? All the different levels that people are at. So you get to try 2 versus a clinician. And now we're asking all these examination questions, like, and putting it together, not only the parts. That's tough, but also the way that we're going to start teaching it, it's still going to have all the parts in it because I think all of those are absolutely necessary for the best clinicians in the world. But we're also streamlining how the seminar is taught. So maybe there won't be quite as much live role play as much as we use each component individually in a breakout. And then we do the live role play for kind of funsies. So instead of that being where you grab the most, but you're like, ooh, I like that was fun. I can see how it all fits, but it's just like it's like you leave people with that, like, oh, I get it, versus really honing in on each subsection. And then if we have them read that stuff and think about it before, instead of having people do what's the white hat? Like, what's the red hat? Like, if you've read that book, you've done this quiz, we do introduce a couple other concepts, you should come in and be like, I kind of got it. And then it makes it way easier for the whole group. And then we can have better conversations and better course. So yeah, I 100% agree with you. We're working on that. And, I have one art of assessment coming up in Wisconsin, which I'm not hosting. They're just bringing me in. I'm hoping all this will be done by then. That's June. But when we have it at our place in August, like that's the big goal is like, hey, it's here at the farm. Like anybody that's coming, like we want you to just be a stud at this. And, yeah, so that's the plan. And realize that any of my courses, if you've taken a course, if you're within 2 years taking the course, it's free audit. And then you guys being residency members, you guys get 20% off anything, whether that's online courses, seminars, so all that stuff. So I had somebody, in case he watches, who was it, Jake? I think he just joined and he had bought the old RX3 course. And he's like, do I have access to that? I was like, dude, I don't even know where those videos are. Like there's a whole online RX3 course that's broken down into like 9 modules now. I was like, sorry, I don't know where this are, but like you get a discount. So I don't know if you guys know that page is on there with that code. So just visit that page in case.
We got 2 couches and an air mattress with your name on it.
Yeah. So we have a guest room. We got a lot of places. That's the hardest thing about our places. I mean, there's a hotel right up the road, but yeah, where to stay cheap is, yeah.
My parents are empty nesters. They take rent too.
All right. Any other questions about anything? And I think, was it you that asked about more business stuff?
Yeah, that was me. Yep.
Yeah. So I'm reposting the old farm business journeys. I'll do them more often than once a week. Like I'll get all those out so you have them. That literally we had 5 or 6 of those that account for everything we've done. And then I would be game to do, we used to do residencies live Thursday night. Thursday night's easier. I didn't want to step on R2P's toes too much. So that's why I was trying to just do it like this. I'm game if you guys are like, hey, this is a good time. We could do an hour just business powwow where you bring me questions. I could have a couple topics dialed up, but more just like a general Q&A on business stuff, and make it maybe an easier time than 2 p.m. on a Friday. I'm game for that, but I would say I can create a poll in the residency page and have people chime in on times. Like I'll give 3 times or a couple days. That's hardest thing is scheduling these things so we get the most people that can come live.
Thursdays would probably be fine too.
Thursdays are good. We're here till 6. So we could literally do like a 6:30 on a Thursday and say, hey, this is just a business meeting. And Alex and I were talking, I'm not opposed to moving these to Thursdays at 6:30. That's when we had like, 20 people showing up and it's a little more fun. It's in the evening, you can have a drink, you're not in the middle of the day. I'm not opposed to that. And I would like feedback on that. We were doing this because this was already in motion. This is when we were doing this. And then we were just letting you guys come in almost as like, hey, you're here if you can be. But if we want more live participation, I'm totally open to different times. I know we're all in different time zones. It gets tough. So comment.
I think Thursdays would be great, but I don't know about other people's schedules too. But I know a couple people, or at least one other student that's at Logan, Jaden, that's in this, and like every other week we're either at like a workshop or something Friday afternoons.
And like I said, the only reason I've been doing these at 2 is we are already doing the week interviews, and it's supposed to be the week interview. I'm totally fine because, R2P is only doing once a month.
Yeah, and they're only
residencies
Mondays and Tuesdays.
Because these used to be bi-weekly every other Thursday at 7 p.m. is when I used to do them.
Yeah.
But now if we work till 6, I would be totally game to do 6:30 p.m. for these. And then if we get way more people, we'll just stick it there. So why don't we do this? I will be game to do, we'll do a week interview. We call it Business Socks. So if you don't know who Flight of the Concords are, go look up Business Socks. And then that's the song we play at the beginning. We will plan on that for 2 weeks out on Thursday at 6:30 p.m. And we'll just run with that. And then if we get a lot more people, then we'll just say, hey, that's when we're going to do them. And we'll see what our staff can do. So that's a harder thing in here is all of our schedules. So, yeah. Sound good?
I know I just coach volleyball Thursdays until 8 p.m. this time, but
damn it, Kaylee.
Better time. I know I have to ruin everything.
Sorry, me and Seth will be
kids. Listen, but if that's a time that works, then I can just watch videos and catch up and do.
Yeah. Well,
if I'm going to be the only one, if I'm going to be the odd one.
Yeah, and we can bounce around. I'll put a poll up on the residency page, probably tomorrow or something, and try. The tough thing is what I'm finding out, which I might have to take I've looked at it a couple of times, Aaron, is looking at Discord or something, because like we just had an osteopath join from Australia, not on Facebook. I can't find the dude anywhere. Somebody else joined that's on a Facebook. Like that used to be a ubiquitous platform. No more people are not using it. So I need something. I wish Squarespace had it internally, which they do not. Discord, the tough thing there is some people don't use that and you have to invite them. So it's like now we have another platform to invite people to. So I'm trying to get something that everybody's on, because we're up to like 15 members now. So I'll use Facebook until people bitch at me enough. So go comment on that and we'll just see what time everybody wants to do. Sound good? And also,
I got one last question. Sorry.
Yeah.
You had mentioned, I forget what you called it. Oh, in your research review on the trigger points, you're talking about Callison's motor index points. It also referenced reflex and Stecco stuff.
Mm-hmm.
I was wondering, I was checking out Stecco's website. It looks like impossible to take their courses online. Have you tried them?
I did the acupuncture Stecco crossover course, which I'm being honest, I wouldn't pay for it again. I didn't know what I didn't know. Okay. It's 8 videos. It's very surface level. It's like explaining what you could surmise on your own, which is kind of upsetting. It's like $30, so it's whatever. Yeah, their website's tough. Their books are tough because it's like a textbook that doesn't really explain the concept. Thanks, man. I appreciate it. So yeah, that one is tough. The reflex stem stuff is tougher because if you don't have old DNS notes, you're not going to be able to get it. Yeah, it's tough because all those courses are private too for reflex stem right now. And then Callison's, like that book is on Amazon, or it's a Kindle version, which if you don't have that, I think it's $15. I might be wrong on that. I would 100% get it. You start playing around with it because that's, again, he took, I want to say 20 years and just mapped acupuncture points, because the whole idea again is what? If there's a theory that if you treat around the trigger point, which welcome to Stecco, right, versus on the trigger point, you're going to have a better effect because you're not having neurologic interference from a nociceptive standpoint. So if I can use an acupuncture point or a conglomerate of acupuncture points around a painful trigger point, get the trigger point, which we know is a big part of a pain generating factor, to go away or abolish, like that's way better, or supposedly for the whole system or the whole human. I'm going to be honest. I have never used Callison points or acupuncture motor index points standalone, because I got to make sure at this still at this point in my career, I make sure I get stuff done. So I'm not willing. I don't have enough time to be like, well, I'm just going to do these 3 points around your infraspinatus, see what happens, and then still have to go back and dry needle if the trigger point doesn't go away. So I do them in tandem, which is what a lot of people do. Now, as I get further down the line and I start using them, I'll start pulling that. But what I'll do? I'll probably treat secondary or latent trigger points with the Callison points and not treat the primary, just so I know, like, okay, I'm getting, and then see what happens downstream. Yeah, it's just something to play with, but that's all good stuff to know. We just found another whole referral system on ligaments. Like there's just a nonstop stuff. So like I said there, if I had to learn points, even though it's the hard material to get, I would share it with you guys, but I don't feel comfortable doing that from reflex stem because it's just like, that's a weird one with DNS. So I apologize. That's what I would learn though, because they have the most crossover of any points across all the systems, whether you're talking Ayurveda, acupuncture, Marma, all that stuff. And I know I'm saying, but I won't give them to you. Yeah. You can find them somewhere, I'm sure.
Follow up real quick. So I feel like right now, a lot of the students, like the trend is like, oh, I got to learn some soft tissue technique. So you're either like, well, I'm going to pay a ton of money for the ART courses, or I'm going to pay for the Stecco textbooks, which is typically like what kids in my tribe are doing right now.
Yeah.
But have you taken a Stecco, like an actual course, or just like the online stuff?
I haven't taken a Stecco course yet, just because time. Like I haven't been, I didn't get to go to Brett's when he brought him in. So that's one where Brett has taught me a lot. just personally. And then I've read, so I think that's one in my opinion, because it's such I shouldn't say comprehensive, lengthy list of points and a variety of points and how they interplay, that I think that's one where you need to understand the concept. Same thing with ART. If you understand the concept of what we're doing, which is kind of the concepts built in or cooked into the technique, you kind of get it. And then again, the more soft tissue techniques you take, you're like, oh, yeah, I kind of get it. It doesn't mean that you don't learn something when you go to these new ones, but that's actually something in my clinic that I do lean on. If somebody doesn't have a soft tissue technique, it's hard to get feel. And you're not going to get that from a textbook. So like, I wouldn't say I require it, but like I did a ton of ART up front. If you don't have that, I think it's just hard. So if I'm like, hey, can you work on somebody's infraspinatus? If they don't have a needle, it's like, what would you do? I mean, you could mock ART, you could stecco, you could, all sorts of stuff, but you got to have some, instrument assisted. Cool. Yeah. Go with something. Yeah, I want to take a stecco course for sure. I'm not going to fly to Italy. I'm not going to, I guess Brett will be bringing them back over either this year or early next year. But I've looked into also bringing a lot of these courses here. It's just so damn hard when you talk about like Shacklock or stecco, because it's not at a mass center. It's just not worth it financially. So yeah, but I don't want to be like, oh, just get any technique. ART is not a bad thing to learn. I know it's expensive, but the anatomy is so clean and taught so well, and they adhere so well to it. And then the technique crosses over. And then you're like, oh, if I'm doing stecco, at least I know like what I'm working through in the forearm from a palpation standpoint. But that could also be, a functional range release, or any of these things are heavy on what? Anatomy. Like I don't care if you're talking acupuncture, stecco, it's all anatomy. And then the technique kind of follows that. Yeah. Anything else? Again, this is your guys' time. This is not being published on the broad internets.
Slim internets.
Yeah. All right. Well, if not, I'm gonna do one thing. I'm gonna ask you guys to do one thing to start a trend. I'm gonna put the poll up for time. I'll put some options up, or maybe I'll just put something up and say, hey, put the best times for you. So I don't have to give choices. So there's more choices. If there's anything besides like business stuff, which I know I wouldn't say it's a pet peeve. I just think it's funny when we say business stuff, because that's like saying, can you teach me about a human? I mean, that's a lot, so we'll break it down. That's why I like Q&A. Like if you can bring me a couple questions per person, it makes it way easier. Otherwise, it's like, where do you want me to start? Can you imagine going to a chiro school and they're like, what do you want to know? And you're like, so then give me some topics that you might want to learn about, whether that's business or clinical stuff, because I'm all about doing case studies, but there's only so many concepts you can hit on because it's dependent on the cases you're presenting, right? So both of these were kind of a fear avoidance motor control issue, almost in both, right? Little tissue adaptation in his, maybe not so much as mine. Same thing. There wasn't anything wildly different in those two cases, which is kind of interesting. So just give me some ideas of stuff you really want to know about. And then hopefully other people that aren't on this video with us will comment. And then we have a really strong list of like, okay, this is what we want to do for the next few months as a group. Sound cool? I guess. We'll see you in 2 weeks, probably on a Thursday evening if people can attend. We'll try to make that one at 6:30. Let me look real quick so I can just see. That would be
29th.
29th. That should work.
29?
Yeah. All right. We'll see y'all then. Have a good weekend.